Well, good morning, everybody. I'd like to welcome you to the Supply Chain Conference this morning. This is a conference that's a partnership between the Supply Chain Management Institute and the Connected Systems Institute here at UWM. We're pleased to have Chuck Jensen on the line. He's going to share some information for us about working with his physicians in a sourcing role. I do want to let you know that the Q&A feature within your window is how you can submit questions. So feel free to submit those during the presentation. Chuck has agreed to field your questions. So as you have them, as we go throughout the presentation, feel free to use that Q&A feature within Zoom. So let me introduce Chuck Jensen. He is the Director of Sourcing and Contracting at Froedtert Health. In this role, he leads the purchasing team as well as the sourcing and contracting team. Previously, Chuck served as Director of Supply Chain at Comanche County Memorial in Lawton, Oklahoma. And there he was the Director of Materials Management, also at McLaurin, Northern Michigan in Petoskey, Michigan, a beautiful place if you've ever been there, Petoskey, Michigan. So let me welcome Chuck Jensen to our conference.
Thanks, Mark, for that introduction. Just give a little bit more about me. Not only have I been at 3 healthcare organizations in my career, but I started my career in retail. I worked at Kmart Corporation for about 11 years in various supply chain roles before coming into healthcare. My education, bachelor's degree from Michigan State in supply chain, and my master's from Central Michigan University in logistics. So apple doesn't fall too far from the tree as far as supply chain and of course working in supply chain now. What I want to do before I start clicking through my slides and you get enamored by all the wonderful information is give you a little bit background about Froedtert Health in general. And I do this only because not all the time am I speaking with healthcare folks, and so you may know very little or you might know a ton about Froedtert, but I want to give you at least a little background before we start digging into this material. First of all, Froedtert Health is the academic medical the health system for the eastern side of Wisconsin. Obviously, UW Health over on the western side in Madison, the other academic health system. We have 8 hospitals currently. Our most recent addition is Holy Family Health System up in the Manitowoc area. That was brought on as part of our health system in March of this year. We have 4 surgery centers, and I want to try to nail down a number of clinics, but it changes virtually daily. So probably, if I were to guess, somewhere in 40 to 50 clinics throughout the area. So a very large health system, one of the 3 in the greater Milwaukee area, the other 2 being Advocate Aurora and Ascension. So what you're thinking to yourself, why am I listening to a presentation from a healthcare provider? And so I wanted to give a little context to this, since my goal here really is to tell you a real life example of supply chain in healthcare. We do a lot of moving products from point A to point B for sure, and that is probably the crux of what we do and people see in supply chain and healthcare for sure. But this is a different viewpoint, and I think worthy of folks such as yourself hearing the good work that we're doing in supply chain with our clinical staff. What I hope you take away from this and try to pick these things out as I go through my talk with you. Demand planning, you should pick that up in here. Analysis, of course, negotiations, contracting, collaboration, product standardization, and cycle time improvement. All those things you should gather out of this as they are part of this presentation, part of our supply chain. I want to give you a little more background again before I dig into these slides. You might ask, why, and maybe your viewpoint is from a physician or a surgeon standpoint, they are the person to determine the product to come in, and all our job in supply chain is to get it for them. And that's true to a very large extent, but it's not completely true in this environment we're in. And I'll tell you why. The cost of healthcare continues to rise. You might hear it on the news, or you may just know this as part of everyday living. Cost of labor, of course, labor is a big factor of our cost structure, but supplies, in supply chain we deal in supplies. The high technology, the innovative things that come out daily into our health system cost more. People want to get rewarded for their innovation, so those things cost more. Well, at the same time, we've got the pressure of those that pay for the services, well, be it the government or insurance companies. They want to pay less, or they want to reimburse us less for those services. So it's this constant struggle of things costing more, but the reimbursement being less. So that's where we need to interject this idea of a balance. We do need to provide this high care to our patients, our community. Of course, we need to do that, but we also need to be very cognizant of the cost. And so there's a balance there. And so that's why we have to really engage closely with those that know the products that we need, and those being the physicians and surgeons. A few terms I want to leave you with before we get digging in here as well. First, the notion of, you'll hear me talk about value analysis. A value analysis is a process, and it's a process where it's broader than cost. It's not just looking at a value, meaning what price can I get? Can I get this item at a lower cost? Can I negotiate for a cheaper price we pay? That's one component of it. But when you talk about value analysis in healthcare, you're incorporating much more than that. And it's a process. It's a process of discussions, of decisions, of implementing contracts, all types of things. It's a gamut. So you'll hear me talk about value analysis, and it's a process. The second thing you're going to hear me talk about is this term SME. And it's an acronym that stands for subject matter expert. And there are subject matter experts throughout our organization. And largely speaking, for this presentation, it's going to be referring to physicians. They are the subject matter expert in their area of expertise, albeit an orthopedic surgeon, a heart surgeon, whatever their area that they are trained in, that is they are the subject matter expert. Now, supply chain is a subject matter expert in supply chain items, but most of the time when I talk today, we're going to be talking about physicians as subject matter experts. The third term I want to leave you with is that of a GPO. You'll hear me reference a GPO. It's another acronym. There's a ton of acronyms in healthcare, but this one stands for Group Purchasing Organization. And in healthcare, most healthcare systems across the country are members of at least one group purchasing organization. And the group purchasing organization that we are members of is the largest in the nation. It's called Vizient. And a group purchasing organization provides tremendous value to the organization on large contracts where they are commodity in nature. And I'll give you an example. If we are purchasing exam gloves, for example, our volume at Froedtert may be $3 million, but if we work together with our member organizations throughout the country, we may have $3 billion in spend. So we can go to the market and get a much better price with our collective spend in that category. And healthcare is not unique to having a group purchasing organization as such. Farming has that. They're called like co-ops. So you'll have a lot of rural farmers that will get together and by themselves may not have a big enough crop to take to market, but collectively they can they can get a better price for their crop. So you'll hear that term, we talk about a group purchasing organization. So let's get into these slides here. And so the title here, Product Change Management Reimagined. What this is, I'm gonna walk you through here is our value analysis process at Froedtert Medical College of Wisconsin, where it stands today, and where we are moving to currently and rapidly implementing a new process moving forward. The reasons why and the value for doing so. I'm going to pause just for a second. And Mark, is there any questions? I want to keep this interactive. If anybody has any questions about any of the terms or material, please don't hesitate to shoot a Q&A in there. It gives me a chance to take a breath too. Hearing none, I'll keep going. Okay, let me talk to you a little bit about our present process and some of the issues that we have with our present value analysis process. There are a number of issues. First of all, we have a variation. By that, I mean, it's the process and policies and procedures we have in place today are not being administered consistently across the health system. We have different groups at each of our hospitals. FH stands for Froedtert Health, sorry. ASC stands for Ambulatory Surgery Center. See, I wasn't kidding when I said there was a ton of acronyms in healthcare. So we have different healthcare settings within our health systems, and the processes of value analysis were being administered differently across each of those entities. The second issue we're trying to solve here is that of a current process is online. We did this a few years back thinking this would be great to move our process from a paper-based meetings, people had to attend a meeting, to an online format. The thought process was great. People could access through their smartphone, their tablet, their computer. They could do it at their leisure, read the material, provide input, and vote at their own time frame. That has been unsuccessful and unpopular since we started this. The third issue that we're trying to solve or resolve is about information. Our initiatives that are put forth today are lacking key information, whether it be pricing, contracting, data, clinical information. There's various pieces of input that often are missing. And what that does is cause a slowdown in the time it takes for a product to be evaluated and a decision. And that leads me to my fourth point, lengthy period of submission, evaluation, approval, and implementation. Believe it or not, you might be shocked, but it routinely takes as long as 6 months for us to go from identification of a product request all the way through implementation. And that's just, quite honestly, way too long for our physicians and our patients to wait for new products to be implemented. And then the last bullet point here on our present issues we're working on here is subject matter expert participation. We would identify subject matter experts from their, their knowledge, their expertise, their, how they're valued and looked at throughout our organization, but they either didn't have the time because their practice was so busy, they were not engaged because of the 4 bullet points above, or a myriad of other reasons, but the participation was inconsistent. All these are the things that are issues that we're working to resolve. So what's our proposal? What are we working on now to improve on that? And what are the features? So first, it's going to be clinician driven. The clinicians are the driving force. They're the ones that have the knowledge on what the products for our patients need to be. The group will be multidisciplinary, although led and the majority will be physicians. You need other inputters, whether that be risk management, infection prevention, supply chain, finance. There's a lot of other folks that have a stake or reasonable and important information to provide to the group. It's going to be collaborative, okay? And by that, I mean, although the physicians are the decision makers, they're going to collaborate and have discussion amongst themselves, but also those non-voters are allowed to provide input and other points of view as well. At present time, that's lacking because of the completely online process. it may be input may be provided, but honestly, people aren't reading and disseminating that information correctly. Second thing relative to the future state, again, positions of the decision makers for the whole health system. This will be system-wide, not by unit or not by entity. It's one group for the whole health system. This will provide standardization and consistency across the board. Next bullet point here around focus. This is a focus on patient safety first, clinical efficacy, and then, of course, fiscal responsibility. But fiscal responsibility should not be the driving force. It should be one of the factors. The key factor here, one of the pieces that's really driving success here is this is a shared savings model. And everybody wants to have newest, greatest, latest and greatest items. And trust me, I'd love to provide it for every one of them, but there's a limited amount of resources we have. As I explained before, there are pressures on reimbursement and rising costs. So this group, the decision is all up to them on how they essentially spend their funds, but it's self-funded, meaning the organization is providing a initial funding for each group. And then the way that the group can get more funds to spend is through a shared savings. Essentially, you save a certain amount through initiatives, and some of that money comes back into your group to spend if you so deem on new products. And then here, future state will reduce the time for remote review and approval to implementation, really speed to value. I'll take another pause to see if there's any questions at this point. Hearing none, I'll keep rolling. Okay, what I'm showing you here is this. Our fiscal year at Froedtert Health goes from July 1st to June 30. So this is up until June 30 of 2021. And what I'm showing you here is the vast amount, the sheer amount of product requests that we receive in supply chain each year. It's a ton. And you can also see by that oval shaped dotted line, just the amount by the three main requesting areas. Really, there's four. I could have expanded that to make more of a circle, but you have OR or operating room. You have, and that's the first two. The FMLH, that stands for Froedtert Memorial Lutheran Hospital. That's essentially think of that's Froedtert, the main hospital there by the zoo. That's they're represented there. The second group there in that oval is the combination of Froedtert Menominee Falls Hospital and Froedtert West Bend Hospital. And then the third group in that oval is the surgery centers. And so we're just looking at the sheer volume of requests. Now, of note here is in the orange, these are one-time requests. And one-time requests, as it would indicate, are those that are just requested once. And there are a number of reasons, valid reasons why you do that. Maybe you have a unique patient need because of a certain anatomy or a previous surgery that it's not a normal product we use, but we need it to take care of our patient. Those are the most common things that are approved to do. But you also see in this data, because our process was so long, of taking greater than 6 months to do this, it led to people putting in one-time requests in order that they could use a product that they felt necessary for patient care, albeit these did not get full evaluation, but they were used as a one-time request. And what I want to point out here is this: whether it's a one-time request or a full evaluation, which the blue bar represents, it still takes resources to evaluate these, whether it be supply chain, clinical, physician. So our goal really is to reduce the one-time request, and it will allow time for a quicker throughput and a more thorough evaluation of the full one-time or new product request. So again, some of this is a review, but I wanted to show again our future state, what we're looking to do here. Again, physician-led, over 75% of the group, each group is made up of physicians. There's a single body approval. And what I want to talk here just briefly about is our current state has essentially a two-body approval. Each group is allowed to approve cost increases or variance from current cost up to a certain dollar threshold. If it crosses over that dollar threshold, it needs to go to a second higher executive body for final approval. What we're saying here is we're putting faith and trust into this new group, the physician-led group, and we're eliminating that second body. It provides ownership. It shows trust with these physicians. The next bullet point here really is the voting approval is complete in real time. While we're not having real live meetings, we are having a live meeting, but because we have so many other locations across the area, just like we're doing here on Zoom or WebEx, we have real-time meetings, discussion, and a real-time vote. That's a tremendous difference from our current process, by which at present time, they have up to 2 weeks to place their vote. So you can see inherently right then, we've speeded up the cycle time. This is work to eliminate unwanted variation. Again, we're going to be addressing both new products, and we're looking for standardization. Again, I talked about reducing the cycle time, talked about the self-funding. This is going to be looking more closely at evidence-based decisions. Again, single body approval also means that there's a single body. And by that, I mean, at this point today in our process, if a product gets declined by the group or voted no, there's this second body that a group could go to appeal their decision. In this new format, there's no appeals process. There's a cooling off or a waiting period before a product could be brought back for a second vote, but not another group to go to. This provides a stronger alignment between supply chain, surgeons, and operations. When you think about operations in a health setting, that's folks that support the physicians. That's all things could be receiving, could be EVS, could be sterile processing. There's a lot of people in that operations bucket. A tremendous improvement on partnerships with suppliers, physicians, and across, of course, the health system. And the SME, and you heard me talk about the SME, subject matter experts, a lot closer collaboration, a lot closer engagement with those SMEs. And we've had tremendous success in involving those SMEs in contract negotiations. And I just want to talk briefly about that because we are great and professional in supply chain and skilled in negotiation with the data we have, but you are a lot stronger in a lot stronger of a position if you have a physician with you at the negotiating table when you're dealing with some tough negotiations. So it's always great and important if you can have a subject matter expert participate and be engaged in contract negotiations. I'll take another break if anyone has any questions.
Hey, Chuck. Got a question for you. I have some experience working with a different hospital, and one of the things that they ran into was physicians had their favorite, let's say, gloves. And so say you had 5 physicians and they each had their own favorite brand of gloves. How do you handle that type of situation and resolve that so that supply chain isn't stocking 5 different types of the same thing?
No, it's no different. Every health system deals with that same issue. And this group, this body would deal with that. And I'll give you a real life example we're discussing at our upcoming meeting. And it has to do with selection of trauma products. And when you think about trauma, you think about if you have a car accident and your leg gets mangled up and the orthopedic surgeon needs to go in and put a plate and screw and whatnot all. We've had, just as you described, Mark, you've got physicians that have a preference, meaning they were trained on a product. They prefer a certain brand for one reason or the other. And I'm not here to argue what someone's right or wrong on their decision making. That's not my position. But this group now, as these accountable care teams are set up, they will work together to make those decisions. It will be the physicians themselves that decide on which suppliers and at what commitment level that we'll make those commitments. So commitment in contracting is tremendously valuable. If I can commit to a supplier 80% or 90% of my spend in that category to one supplier, I'll get a tremendously stronger price position than I will if either I give no commitment or I give a commitment of 25 or 50%. And these physicians know that, and their vested interest is to, if you will, fill their bank up so that when they have real need, they could spend the dollars. So that's how we're approaching it. We've been very successful so far. Now, you reference things like gloves and gowns and whatnot on there. There are very unique circumstances, and you really take those on a case by case basis. Sometimes for gloves, we've had issues where there's allergies to certain components of a surgical glove. And so that's where you don't commit 90 or 100% to one supplier. You may only leave your commitment level at 75% because you know you're going to need 20 or 25% for those times when you have individuals that have a preference. And I use this slightly because most of the time it has to do with an allergy or some unique sizing situation. So they are unique. There are give and takes in this, but you're right, Mark, you do see a lot of that. Okay, again, this question about value, and I talked about in the onset here, value is not just price, okay? In healthcare, value, and I'm sure this transfers into other industries as well, value looks at quality of the products. It might, in this day and age, it might be, can you deliver it to me in this century, or is it stuck on a ship somewhere out in the ocean? Value is different, not just cost. Okay, so in healthcare, here's some examples of value. Is the product going to provide a lower infection rate? Okay, infections in healthcare, you can imagine for the patient, it's no fun to have an infection. But for a health system, if a patient develops an infection while they're under our care, we do not get paid for that care episode. We have to still treat the patient, but there's no payment for us if they develop an infection. So wherever I can reduce or eliminate infections, that's of tremendous value. Second one here, less blood loss. The less a patient needs blood provided to them, tremendous value. Blood's in short supply, extremely expensive, and there's a lot of clinical benefits to not have to get blood. I'm not clinical, so I can't necessarily speak on this, but I know there are benefits of that. Length of stay, think about it from a patient standpoint. You want to get home, you want to heal in your own bed or lay on your own couch to complete your healing process, not sit in a hospital bed. From the hospital standpoint, the quicker a patient can be discharged to go home, the quicker that bed can be used for another patient waiting to have care. Avoidance of a second procedure. A lot of times this happens in surgeries related to orthopedics or spine, where a patient has an infection, something in the anatomy, or for a myriad of reasons, they have to come back for another procedure. They call it a revision. That's similar to an infection. If you need a second procedure within a period of time, health system doesn't get paid for that all for that second procedure. So you can see the value then if we can eliminate the need for a second procedure. And of course, I wouldn't be doing my job if I didn't mention cost, but it does belong as part of an example. But I wanted to highlight the other examples that when we talk about value in healthcare. So this is just a schematic I want to share with you about how our accountable care teams are set up. The things in the bottom left, the goals are ones that I've already spoken about. The lower right section are the teams that we've identified. Just from a perspective, our current structure has 12, I think even more than that, 12 teams. They're very specialized. When we set them up with the idea that they would be specialized, that the folks that were the subject matter experts would think that would be great because they're talking with their very specific colleagues. what we found is there's too many. So we are going to reduce the number. Right now, you see on the schematic 7. We're actually in talks to see if that may even be too many. Then maybe the correct amount is 5 or 6, but not 7. So you'll see there in the left part of that that box, orthopedics and plastics. That's the accountable care team that is in place now. It's been live since July 1st. We've met now 4 or 5 times. It's the one that I think is very successful and will be the springboard for us rolling out the same methodology and structure to these other accountable care teams. Each of these accountable care teams reports into a larger body. Now, it's not a secondary body for approval. It's a body for reporting and providing updates as far as how the groups are doing. That's called the VBCE Non-Labor Committee. And again, true to form, we've got a lot of acronyms here in healthcare. VBCI stands for Value-Based Care Initiative, and there are a numerous amount of committees throughout the health system, all structured to generate value for patients, employees, and health system in total. Just drilling down into the ortho and plastics accountable care team so you can see the types of members and the amount that are participating. We have 2 co-chairs, and for each entity or facility, we've had members on the left. I'll go from the left to the right. We've got members from the main Froedtert Hospital. The second over is Froedtert Menominee Falls. Then there's Froedtert West Bend, and then to the far right is the ambulatory surgery centers. You can see towards the bottom, those are all voting members. They're all physicians. And down on the bottom, you'll see that bracket for non-voting members. Those are the other members that are the collaborative, multidisciplinary folks from anesthesia, frontline staff. That could be nurses, could be a number of techs, a lot of different inputs there. You have supply chain, you have quality and risk management, you have infection prevention, a number of other participants in the group, but non-voting, just inputs. Real high level process that the group takes to evaluate a product. You have a request. The second process, it goes to the accountable care team for a review. There's a presentation, then a decision. Then the internal piece is where maybe a contract needs to get finalized, item numbers in our material system get generated, preference list gets modified within the OR, and then after the implementation, then there's a period of time where there's some follow-up to make sure that the value that was identified is being realized. This slide really is to depict the data that we use within the process in the health system. I took the physician names out for obvious reason, but you can see on the left, it represents the 3 hospitals, Froedtert Hospital, Community Memorial, which is now Froedtert Menominee Falls Hospital, and then St. Joe's nomenclature now is Froedtert West Bend. And you can see where the spend is happening in each of those hospitals by month. And then to the right, where I blacked it off was the actual physician name, but you can see it was essentially showing what physicians using this product in question and at what level. And this helps generate collaborative discussion when you can see where one physician is using the product at a high rate and another is not. And you can have discussion on why one would use the product and why one wouldn't. And that generates real collaborative discussion. Just clicking through these really quickly. I'm trying to be cognizant of time here. This is the supplier submission criteria. Essentially, we've, as part of the speed up of this process, we've compelled the supplier to help provide data. And these are the various output or inputs of data: pricing, model numbers, any recall information, any training is going to be needed as we implement, things of that nature. There's a clinician validation. By that, I mean, physicians have a stake in this too. If they want a product, there's a series of questions they need to answer. Everything from, is there a conflict of interest to them, to what do they expect to get out of the product? You know, why? The answer, you know, the gorilla here is why. Why do we need this? What the value is going to be, and then any other cost, benefits, timelines, investment, anything of that nature. A real life example here of one that went through this process just a couple of months ago, product called Galaflex. And this is the actual presentation that came to the group. Identifies at the top who the requesting physician was. It talks about whether it's been FDA approved, that there's no recalls presently there, and just purpose and outcomes, a couple bullet points on why, you know, the why, that's an alternative. It's for breast reconduction. It's a less expensive alternative to the product we're using today, lower infection rates, and then it identifies the current product of Alloderm. Second piece around the Galaflex, again, more clinical information on the product so that the physicians can see the differences. So on the graphic below, it shows some different manufacturers of a similar product, and they can see the differences from the amount of time it takes to absorb, to the size, specifications, and structure, and things of that nature. So this is my last slide here, but I want to spend a little bit of time on it here. The slide you see here is the third iteration of this. So first of all, what this is showing you here is when we put these slides together for presentation, of course, they want to know what, they've seen the slides already on what it means to them clinically, like what the product's going to do for them and their patients. But now this slide's saying, what's it going to do for us financially? Because everybody's now really keenly aware of what that's going to take out of their bank or put into their bank potentially. On the surface, you can see that our current product has a unit cost of over $9,100. And this current product that they're proposing is much, much less expensive at $2,200 each product. So per procedure, it's almost nearly $7,000 per procedure savings. And so annually, it would save us $62,300. But let me just stop and tell you again, this is the third iteration. When we first did our analysis, this was going to cost the health system almost $400,000. And here's why. If you look at the top there, again, we're part of a group purchasing organization, and we've previously committed our spend at an 85% level to Allergan, okay? And so we've given them our commitment. We have a contract that we're going to spend 85% of our spend in this category with Allergan. If we moved the product away to this proposed product, it would put us in violation of that commitment. Now we take our commitments very seriously, and there are penalties if we do not. And so we would have saved a lot more money, but we would have been in violation and seen a tremendous penalty, the tune of about $400,000. So that quickly puts us in a negative value position. So we went back and shared the information with the physicians, and what they said is, okay, this is good information. Let's go back and relook at the clinical data. And they said, based on this clinical data, we feel it's most appropriate for this very specific subset of patients. And we feel, based on the last 12 months, that we would have used this product around 9 times. So then in supply chain, we ran through a scenario, put some analysis together, and said, if we use that product 9 times, we would not be in violation of our contract. And so that's what you see here in front of you, where we did in fact agree to use and convert these 9 uses of the Galaflex. And if we do that, we can stay in compliance with our contract and save the value of the $62,000. And in the third value here is the patient these 9 patients that it's most appropriate will see value for themselves. So I wanted to spend a little time and explain that piece of it, that what you see is sort of a pretty picture, but there was a lot going on behind the scenes here. So that's that's the last of my slides. Appreciate you taking the time with me today. I hope I hit all the objectives and shared with you about demand planning, analytics, negotiations, contracting, collaboration. And then one of the ones that I think the most that we're seeing the most here, not that they're all not happening, but cycle time. We've seen tremendous cycle time improvement by having these meetings and having a good structure around that. So with that, any questions from folks?
Hi, Chuck. Referring back to the graph from a few slides ago, you showed one-time requests far outpacing the, I think they were called new product requests. Can you talk about kind of specifically what has been done or what is currently being done to try to convert those one-time requests into the process of a new product request?
Yeah, I sure can. And I can really only relate it to the ortho and plastics group because that's where we have started our pilot, and I have the most experience with that. And where this is important is we have two co-chairs of this group. And when a one-time request comes in now as part of this process, it comes to these two co-chairs, and they themselves, as being subject matter experts, they evaluate it quickly to say, do you really need this? Do we have something else that's comparable within our health system already? Or are you just putting this in as a one-time request because really you want to start using it and you are frustrated because it's taken so long to get your product reviewed? So your strategy is to put it in as a one-time request. And that's where we've seen a tremendous reduction in one-time requests because we've identified them as not a real emergent one-time request, but essentially, yeah, I really just want to use it long-term, but I'm frustrated it's taking so long. And so we've, through speeding up the cycle time, we've converted the one-time request into the new product request and seen a tremendous reduction already.
Great. Yeah, thanks for that. So improving the process, like you said, speeding up the cycle time there helps people move away from submitting those one-time requests.
Exactly.
Another question for you. The last slide that you showed where Allergen had been committed 85% of the volume, and we've got this competitor that looks like it's about $7,000 cheaper. Do we know if the competitor was considered at the time that the commitment was made to Allergen, or was this a new product on the market since Allergen was released? I don't know if you're able to disclose any of that, but has there been any investigation done in that matter? Maybe why it wasn't chosen originally?
I can tell you two things that I know. Number one, our commitment to our 85% commitment was done at least, I want to say, yes, I want to say 2 years ago now. We're in the final year of our contract. So that's one piece of it. A couple of years ago, we made our commitment. Number two, this GalaFlex product was not one that, I can't say for sure if it was not out to market, but it was not one at that point in time was desired or brought to our attention that there was a clinical need for it. And so it's important, and I'm glad you brought this up because there is a tremendous difference here from, it's a $7,000 difference. And we are in the last year of our commitment here, and it will be a definite discussion point when this, our commitment comes up for discussion, renewal, renegotiation, whatever term you want to use. We may, in fact, come back to this group and say, okay, guys, now we're not constrained by this commitment. Do you want to move away and move completely to the GalaFlex product? And then we would realize, you know, I think the factor was somewhere for 450,000 in savings. So a big shift, but we needed to stay compliant for at least the next year while we ran out of our commitment.
Sure. Yeah, thank you for that. sharing what you could, what you were aware of on that historical process. We do have a question here from the audience. Do large GPOs like Vizient have a product approval process, or is that done at the local level?
No, they have their own value analysis process that takes place, and that's really, I appreciate the question, because it's really it's really put out there so that if folks don't have their own value analysis, that they can rely on Vizient, that they've done that approval process already. Smaller health systems may not have a value analysis process or committee. They may look at the value analysis data and studies that have been done by Vizient and just use that as their use that as their guidepost and move forward. At Froedtert, as an academic center and very large and collaborative, we want to be sure to engage our physicians in that process, and so we do a second value analysis ourselves. But no, you're right. Vizient, the other two GPOs in the nation, or large ones anyway, are Premier and Health Trust, and they each have their own process to validate products. Largely from a clinically they have a criteria that says, are these clinically acceptable, is how they will term it. And they may have, sometimes they have thousands of products on contract, and they're varying levels of quality, but they're all deemed to be clinically acceptable. And so then at Froedtert, for example, we further look at those products and say, for this type of product, which product do we deem is clinically acceptable for our patient demographic and our acuity level, and a various number of criteria, and then we make our own decisions.
Great, thank you. Thank you for that answer. I'll pause a second here, see if there are any other questions from the audience before we wrap up.
Mark, I want to just tell you how much I appreciate you welcoming me and asking me to provide some information. I hope it was beneficial for those in attendance. Always happy to share context and a different perspective. A lot of times, at least when I went to school, a lot of the things you saw in supply chain courses were around transportation and manufacturing and different industries. I never thought I'd work in healthcare, but supply chain is tremendously valuable, and especially at this point in time with the pandemic, we've been called upon, we've been elevated in our supply chain, and it's just I really enjoy having the opportunity to speak in front of you today.
Great, thank you so much, Chuck. Appreciate you sharing the information and kind of pulling back the curtain a little bit on the behind the scenes process that sounds like it's really been transformational for you at Froedtert. For everybody on the line, we are in the middle of our conference here, so I want to point you to the upcoming sessions. So at 11, Tom Deary, who is the CEO of ISM, he's going to be talking about what to expect from your supply chain in 2022. So that should be interesting, looking at trends for next year. And then you have a choice between his presentation or Victor Baez from Rexnord at 11. He's going to talk about steps that you can take to digitize your supply chain to be more connected with both your suppliers and customers. So I encourage you to choose from one of those two presentations coming up at 11 o'clock. Use the link within the email that you received either yesterday or this morning. At noon, grab a sandwich and join us for a Connected Systems Institute tour of their test lab. So they're going to take you through a recently constructed test lab that has been implemented here on the campus at UWM. And then come back at 1 o'clock. Bill Stewart is going to tell you about how to make your supply chain more agile. He'll talk about what they have done at Kohler to really increase their agility of their supply chain. So stay tuned, stay engaged, and we'll wrap up this session. And thank you again for attending. And thank you, Chuck, for all the information that you provided.